Good evening, dear colleagues. My name is Sebastian Dîrzu. I live and work in Cluj-Napoca, Romania. And please allow me to start by thanking the organizer for this invitation. I'm honored to be here with you. I will talk today about sciatic nerve block. It is a lecture about the technical aspect, not that much a scientific lecture. Just a few images from my city and my country. Cluj-Napoca is located in the center part of Transylvania. We have some beautiful things to show you here if you're interested to pay a visit. Maybe you'll be interested to know about the Romanian Association of Regional Anesthesia, who has activity in this city and organizes a congress every year. A good place to start when you want to learn about sciatic nerve block is this paper, and I recommend you all to read it. We always like to say that regional anesthesia is applied anatomy, so it is important to know anatomy. The sacral plexus originates within the pelvis from the lumbosacral trunk, the first to third sacral ventral rami, and part of the fourth sacral ventral ramus. The sacral ventral rami enter the pelvis through the anterior sacral foramina and converge to form a flat net band. The sacral plexus is characterized by a triangular shape with the base along the sacral foramina and the vertex at the greater sciatic foramina. It lies ventral to the piriformis muscle and dorsal to the presacral fascia, which separates it from the intrapelvic fascia. The sciatic nerve constitutes the primary terminal branch of the sacral plexus. It is derived from the lumbosacral trunk and ventral rami of the S1 to S3 spinal nerves. It is the largest and the longest peripheral nerve in the body, extending from the inferior aspect of the piriformis muscle in the gluteal region to the apex of the popliteal fossa in the distal posterior thigh. The sciatic nerve trunk is composed of two major components, the tibial nerve and the common peroneal nerve. These independent nerves do not mix fibers, but share a common trajectory until they physically diverge from each other, typically within the popliteal fossa. The lumbosacral trunk and the anterior divisions of the ventral rami give rise to the tibial nerve, and the posterior division give rise to the common peroneal nerve. The tibial nerve is the largest, located medial and slightly anterior in relation to the smaller common peroneal nerve. The sacral plexus provides sensory and motor innervation to the lower extremity, including the hip, the knee, and the ankle joints. The most important branches for lower extremity surgery are the sciatic and the posterior femoral cutaneous nerve, as well as their respective terminal branches. Please notice that the posterior part of the thigh, it is innervated by the posterior cutaneous nerve of the thigh and not the sciatic nerve. So if you want to provide analgesia in this part, you need to make a very proximal sciatic nerve blocks. Basically, you want to block all the sacral plexus, because actually the spread to this nerve here will create anesthesia in this part of the body. Otherwise, doing a popliteal sciatic nerve block, it has the same effect in terms of analgesia. In addition, there are some also nerve to quadratus femoris, inferior gemellus, the superior gluteal nerve, and branch of originating directly from the proximal sciatic nerve, and they are providing innervation to the posterior aspects of the hip joint. Also, when we are talking about this anesthesia, it is important to notice the variability of the superficial of the saphenous nerve, who may extend in this part of the foot. And what it is important is that if you want to provide anesthesia for more proximal surgeries, you also want to block the saphenous nerve. For instance, if you want to do an amputation on transmetatarsal region, Sciatic nerve may be enough to block, but if you want to do a transtalar amputation, then you also need to block saphenous nerve. And of course, if you want to have surgery on the calf, you need to block also the saphenous nerve block. But otherwise, they are possible. If you block them both, you don't need spinal anesthesia, for instance, to perform amputation in this part of the body here in the medial calf. You just do sciatic and popliteal region and saphenous block, and that's enough. It is also important, this slide, to be understood. It's important to understand that a common extraneural connective sheath surrounds the tibial nerve and the common peroneal nerve to form the main sciatic nerve trunk. The fascicular component of the two nerves are separated by a septum called compton Creux-Weill septum and is composed of connective and adipose tissue within the main sciatic nerve trunk. A peripheral nerve consists of neural and non-neural components that together create a functional unit. The neural component is formed by axon, and they are the cytoplasmatic neuronal extension that conduct the electrical signal from the cell bodies located inside the dorsal root ganglion. From inside outward, the non-neural protective layer consists of endoneurium, perineurium, and epineurium. Individual axons are surrounded by the endoneurium, which consists of fibroblasts and their products like collagen and extracellular matrix. Groups of axons are bundled together into fascicles by the perineurium, which is composed of the squamous cells that share tight junction and are arranged in multiple concentrical layers intercalated by basal lamina. Each fascicle contains multiple axons and capillary blood vessels, and they stay together with loose connective tissue matrix of the endoneurium. The perineurium creates both a physical and a chemical barrier, and functionally they serve like a blood-nerve barrier. The epineurium is the most outermost connective tissue layer and encompasses two anatomically distinct components. The inner interfascicular epineurium, it's composed of fibroadipose connective tissue, and the outer, the epifascicular epineurium, it's in the peripheral and connects to adjacent extraneural tissue. The extraneural connective, also known as the paraneurium, it's a loose connective space that is directly connected to the epifascicular epineurium. And this subparaneural space, it's found around larger nerve structure and provide a path for longitudinal nerve motion, especially around joints, functioning like a gliding layer for the nerve and offer protection against neural trauma. And this is the place that will be the target of our needle placement, and this is the place where we will spread our local anesthetic. So as long as you stay outside of epineurium but inside the paraneurium, then you are safe and you are able to provide a good quality anesthesia or analgesia on the sciatic nerve. Also, it is important to understand that the neural tissue in the sciatic nerve do not divide, regroup, interconnect, and reorganize to form intraneural plexuses like brachial plexus, for instance, which means that if you are stay outside in this direction, you are safe and you will not create neural damage. As I said, I will not talk that much about the proximal sciatic nerve block because it is not that useful for anesthesia because it will not create analgesia on the proximal thigh. It is important for chronic pain diseases if you want to do like piriformis muscle injections, but that's a different thing and we will not talk about it. Instead, I will talk about the popliteal sciatic nerve block because this is very useful for clinical purposes in anesthesia. And for this, you need to be able to identify the sciatic nerve and to scan in popliteal region until you see the spreading in its components. Basically, you place your transducer parallel with the biceps femoris muscle and look at the popliteal artery, and in this space you will see the sciatic nerve or the tibial and common peroneal nerve, depending at the level you are. You make the scanning and you choose your needle entrance in a place where you can still you see the both nerves, but they are still bounded together with the same connective tissue. I will show you the scannings. You can place your patient in every position. You can stay on the belly, you can stay on the back on a lateral position. If it's possible from the technical point of view, I prefer the patient to be on the lateral side, but sometimes it's not possible. Then I ask someone to lift the calf and I put my transducer under the patient and I work in this position. This is what you need to be careful. I saw many times that the probe and the needle are not in good alignment. So if you want to have good success rate with this block, you need to have a good alignment of the transducer with the needle, not like you are seeing in this picture. Another good paper, if you want to read about the sciatic nerve, is this one. I invite you to read and to understand it because it's very, very good paper. It's about how to perform the sciatic nerve in the subparaneural popliteal space. These are the advantages of this approach. In this position, the paraneural sheath is very easy to be visualized. The two nerves have a special appearance that it's easy to recognize with the ultrasound, and it compasses both nerves, making the spread of local anesthetic very good. And you also have small grooves between the two nerves where you are able to put your needle with high success rate, facilitating atraumatical needle placement. So you'll create good quality anesthesia or analgesia without risk of neural damage. And this is the target you want to place the local anesthetic, as you see in this green area here in the conton space. And this is a movie from a dissection performed by my friend Mario from Madrid, where you can see after he injected the dye in the subparaneural space, it is showing you how the neural structure are unharmed and how the local anesthetic, supposedly, so the dye, spreaded around the neural tissue. Okay, so see how the nerves, the neural tissue are not damaged and the dye is not injected into it, but around it. And here just another slide to remind you what is the purpose of the injection. So with green you see how the local anesthetic should be surrounding both nerves, and here is what you will see on the ultrasound machine. So the black is the local anesthetic solution around the nerves. And now some movie. This is an initial scanning. See, now you have the tibial and the peroneal nerve, and now sciatic nerve. So this is proximal, and before it was distal. And now see how the needle it's approaching. And remember I told you about that small groove here, and you are trying to enter with the needle in it. And when you try to inject, you need to see the local anesthetic spreading around both nerves. This is not a good spread. See how the local anesthetic is going far away from the nerves into the submuscular tissue. You are advancing more without piercing the neural tissue, just the fascial layer, and see how now the local anesthetic solution is spreading around the neural tissue inside the subparaneural space. This is a good injection. If I am not satisfied with the local anesthetic spread and it's not going around the nerves, then I will need to replace my needle and to make a secondary injection. Here it's another example. See how I already injected in the upper part, and see how local anesthetic solution is going in this part, but I don't have spread of local anesthetic here. So I remove my needle and I am entering again in the subparaneural space. See again how I go tangential with the neural tissue under the subparaneural sheath, and I inject again, and now the neural tissue is perfectly surrounded with local anesthetic solution. And this is a good block, and you have a good quality analgesia or anesthesia for your patient without harming the neural tissue. Here is another example. After I finish the injection, I look up and down. So now I'm in the middle of the thigh, and see how the local anesthetic solution is around the nerve all the way up and down while I'm scanning with the ultrasound machine. And when I see this image, I'm sure 100% that the block will work. Another example, see now, it's a very skinny patient, an old patient. See the damage of the artery here, the atherosclerosis, and see how, because the fat is missing, it's somehow hard to identify the neural tissue. But if you have a good quality ultrasound machine and you remember that anisotropism, it's something that you will help you identify the nerves, and I am entering with the needle in the subparaneural space, and I'm injecting, and see how the local anesthetic is going around the nerves. But again, I don't have local anesthetic spread in the upper part, so I will have to reposition my needle. Okay, so see how I'm injecting, and the local anesthetic is surrounding this part of the nerve. And because I'm not satisfied with the spread, I go again in the upper part and I do another injection. See how my needle, it's almost touching the nerves, but it's not actually touching the nerves. It's going parallel with it, tangential, but not into the neural tissue, just in the conjunctive sheath. And now I have a good spread of local anesthetic. See how the neural part is staying here, and how the local anesthetic is like a dissection of the conjunctive tissue from the neural tissue. And this is the image you need to have at the end of your injection. See both nerves distally, sciatic nerve proximally, surrounded with local anesthetic solution. And this is another example, and now you can see how my needle is placed between the tibial and peroneal part of the sciatic nerve, and when I start to inject, only with one injection you can have good spread of local anesthetic around both nerves. So this is also possible. Sometimes you cannot do it, but this is the perfect way how to perform a sciatic nerve block, with the needle placed here between the two neural components, and with one injection you see spread all around here. Okay, so with practice you will be able to do this injection only with one shot, but otherwise doing both two injections, it's also good, as long as you understand that you need to have spread all around the neural tissue to have good local anesthetic. If you don't have good spread all around it, you'll have patchy anesthesia. This is pretty much it. I just want to take the opportunity to show you that my hospital is an approved ESRA training center, which means that if you are young and you are a member of the ESRA, you can apply for a fellowship to come to spend a few months with us. We work in an orthopedic department, very, very busy. We have a lot of surgeries, and you can participate with me and my colleagues to do a lot of blocks. And also, I want to tell you about the National Congress of the Romanian Association of Regional Anesthesia and Pain Therapy. I'm organizing the 9th edition already, which will be next year, and you are invited to attend because it's the collaboration between Belgium, Ukraine, and Romania. And here I am with the Ukrainian panelists, with the Ukrainian lecturers who attended this year edition. Thank you so much for the invitation. I hope you'll find the information useful, and good luck with the Congress, and I hope for peace and for safety for you and all your families.